So we're at week 4. This is 1/3 the way through. Now, your exam scores will be out Saturday about 2 o'clock. When I'm done putting them up, anybody with a 78 or less, please make an appointment to see me. I want to review these exams, all right? Show you the trickiness in them and help you understand what these concepts are that you have missed because you're going to see them again on either HESIs or your NCLEX, and we want you to do well in pediatrics. Now, week 4, you do have one CJ Sims and a discussion question, so that to be there. And you do have a quiz on week 5, which is on this stuff right now that we're going to be talking about. Now, I did do a PowerPoint on Monday. Usually I don't get that, but they get an extra half hour of time because they were off last week for Martin Luther or the whatever 2 weeks ago. So they had extra time put on their class to make that up. So I have a PowerPoint recording I'll send to you if you want to listen to that too. But I'm going to do a Kahoots with you. So let's do that. And I'll be talking over it and I'll get you to understand what you need to know. Hmm. Anybody have any questions? All right, let's get started and get her done. Week 4 has got a lot of interesting things in it, and some of it is the variations between adults and children and infants, and how do we deliver care. So early detection of a hearing impairment is critical. Which one is of primary importance? I mean, if you can't hear, what does that affect? Right? If you can't hear, what would that be a difference? We have the impact of cognitive sensory impairment, we have family-centered care, and then those variations, and we'll go into it with these Kahoots. So if you can't hear, you don't know how you're pronunciating. And one of the things that would make us do a hearing test is if a child wasn't speaking, if their language wasn't, they're doing the words like one word by 1 year, or if they weren't hearing noises. That's easy. But sometimes it's just the speech is garbled. So we want to first make sure, are they hearing correctly? And then we'll go from there. A multi. Toddler's playing outside, gets a laceration on the forearm, and he needs stitches. What can make getting stitches easier on a toddler? This is ages 1 to 3.
Distraction.
Well, this is the one that we want child life. Now, I'm lucky where I live in Miami, the hospital here has an incredible child life team. And before stitches or before IVs, before many procedures, they'll go into a room and they'll explain it. Let them touch it. The kids can ask questions, and then they're not afraid of what's going to go on. Yes, we're going to use numbing cream, absolutely, but it's that explanation. The cream is on, so now the area is numb, so you feel touch and you're not going to feel sharp. And I'm never going to let them see sutures. That's got a big sharp needle on the end, so I wouldn't let them see the equipment in this regard. And you don't
So
want to
the
mummy them.
so the answer was the numbing cream.
The child life. A parent
Oh, the
recognizes that her
distraction.
toddler has a speech delay as compared to her older siblings. Your nursing priority. Speech delay now. We use child life to explain things. And absolutely, we're going to use numbing cream, but it's the child life's telling them what the purpose of that cream is, right? So now they are not as afraid, they know they're really not going to hurt. So again, speech delay, number one, rate to hearing evaluation. We don't know they need speech therapy yet. We got to make sure they hear first. Speech therapy might be the second thing they do, right? First, we got to check that. Multi. What are signs of an early indicator of impaired cognition? So, cognition, we know we look at growth and development all the time, right? So, what are some signs that you might see? And all of these are delays, right? They're not verbalizing. There should be one word, at least mommy, daddy, by 1 year. They can't grasp objects. They should be reflex and then, voluntary grasp, by 3 months, and they're not. And then, of course, behavior. And why behavior difficulties? And these are your older children, is because they don't know how to tell you what they want or they're afraid of or what they it's just they're frustrated because they don't understand. Their minds are not working the way that they should. A child's being treated for a fever. What's the reason that we treat a child's fever? Do we have to treat a fever? I put this question in here because it's one of those misnomers that, fevers are a dangerous thing. And once you have a fever, usually the risk of life threatening or seizures is down to nothing. The fever, once you have it, you're safe. The only reason we treat it is for that relief of discomfort. Now, a kid who has a fever is not going to drink, not going to eat, not going to play, not to be active. As soon as that fever goes down, they're eating, they're drinking, they're playing, they're good. That's a kid. So the fever, once you don't have it, and then it goes up quickly, now that's your febrile seizures. That's usually no fever. Half an hour later, you're 101. That quick, what we call rate of rise, sparks the brain, and that's what causes febrile seizures. I've had children over 106. I have never in my career seen anything seizures due to high fevers. Okay. So it is only to relieve discomfort. How do you feel when you have a fever? Horrible. A multi. A child's got something, complaining something in their eye and it's causing them to tear and pain. What are you going to do about that? Well, it says if anything's floating around there, you can take a corner of a tissue and get it out. That's what the book says. Also, if something is sticking in the eye, never touch it, leave it alone. And we put on what we call a Fox shield. It's an eye patch, but it's stiff and it's like metal on it. So it just holds it in position. And then we always check the eye for reaction to make sure the pupil's still working. But anything penetrating, stick it on and get them to a pediatric ER or a pediatric ophthalmologist to take care of it. Leave it alone. Don't touch it. Separation anxiety in a child hospitalized. What behavior indicates the stage of despair? There's 3 stages, right? We have one where they're going crazy and crying and screaming, and then they regress, and then they Don't want mommy. It's like, you're not here anymore. You haven't been here. And those are the three stages. When they get to the point of despair, um, they are getting into, "Oh, all right, I start sucking my finger. I might be incontinent. I might need a diaper on. I might get more infantile." But that's their way that they deal with stress. And that's what you see. That's the second stage. A child with a history of abuse, which therapy explores emotional problems. Kids don't know how to express what happened, right? They don't know if it's right or wrong. But if you let them play and show you, it's a way that's non threatening and you get to understand what went on, right? And we call that just play therapy. It just tells a story. Kids tell your story with, dolls and animals and stuffies and all that. Another multi. When can children react to stress and anxiety of hospitalization? Hospitalization is pretty stressful for kids. We have other people touching them. They don't like all of that newness of people. And then, of course, the things that cause pain. There before, during, and after, right? And the thing is, children with this also can go home with that sort of fear in them. So again, allowing these children and warning parents, to talk about it. Children who are in the hospital more than other kids, like let's say a child with sickle cell, with chronic sickle cell attack, crises that need to be admitted, they probably are going to be more stressed than a kid who's never been there before. Really, it's that one who's used a facility because they know what can happen. A multi. An adolescent goes to the ER for treatment without the parents. How do you get consent for treatment? You'll always see on HESIs and NCLEX something about HIPAA consents. Very important to understand this. A child who's 18 and cognitively aware, competent, will sign their own consent, and you as a nurse need to ask the child if you can talk to their parents. Okay? So that's a HIPAA thing. If it's an emergency, if they're going to come in, you don't need any consents. Two physician signatures is fine, and you get the consent when you can. And then, of course, you could do that too. Person consent, and usually it's the clerks in the ER that get that done, 2 clerks. You don't need nurses, it's just consent for treatment. A child is extremely fearful of hospitalizations. What type of play explores these fears? Like telling me what's happened before, right? And it's called dramatic play. So, I mean, you've seen kids, there's all sorts of plays that you need to know. They're all got a purpose. These are telling you things, these types of plays. When checking the IV in an infant, you notice that the tissue around the IV is swollen. What do you do first? I mean, infants, you put an extra 20 mLs into a hand or into a foot or a head, because we put them there in some. It's a lot of fluid. Number one, stop. And then you inspect it. If it's swollen, there are fluids gone in there. So then maybe put a hot pack on it, elevate it if possible. And depending on how caustic was that infusion, they might have to do, insertion of that regitine to increase the circulation there. But first of all, stop it. It's like blood transfusion reaction. First thing, stop it. Very good. In helping a child to adapt to a hospitalization experience, The best approach is what? So they're in a hospital. How are you going to make them, you know, be more comfortable? Because it's a scary place. And it's number one is the routine. Yes, toys, food, those sort of things are important, but it's the routine. And the routine knows that lunch comes here. These are the foods I'm getting. If they can get the same foods, I mean, mommy there, of course, is number one if we can, but it's the routine that also gives them comfort, especially toddlers. When assessing vision on a child, the healthcare provider would use a Snelling chart at what distance? Taking you back to health assessment, right? 20 feet. And we know if there's problems, we need to report it. A multi. Nursing care of discharging a child to home. We know we plan discharge on admission all the time with teaching, right? From the moment they get in there, you're talking to the parent, to the child. So discharging shouldn't be that difficult if done right. So what is it that you only want to give this instruction to the parents? Older children need it too. There are some even school age children who want to sit there and read it and to understand, right? But let them know, what do you expect to happen? When is the wound going to heal? When are they going to feel better? And then who are they going to call in case of problems? And did they understand it? What is a 3-year-old's biggest stressor of being hospitalized? That's right at the end of toddler, beginning of preschooler. And it's that separation from parents. They want mom or somebody to be there all the time. And this, if especially if you have a cognitively delayed child, like a Downs child, an autistic child, you really want to promote to have somebody there because these children especially need those parents. A multi. What is the best way to alleviate and stress and anxiety of a hospitalized child? Best way. I know there's two answers you're looking at. Which one is it, right? And it's that keeping that child the same routines, absolutely, but allowing the parents to stay there and always, always, always get on their level. Let them know what's going on. Kids are smart, even your toddlers, they understand and they really want to know. And we do not do invasive procedures in the room. We take them to a treatment room or somewhere else. Their bed needs to be a safe place. They don't have to worry about anything in their own room, their own bed. A nurse notes a string tied around an infant's wrist. An appropriate intervention is what? Like, why is that string there? Is there an IV there? Do I need to take it off? And find out what it is. Sometimes they're, luck charms or things. I know with the Hispanic population, they have this little called cat's eye, and it's this little black, little white, looks like an eye, and they have them in medals. They have them in necklaces and bracelets, and these things are to ward off bad feelings towards them, and they're important. So always ask before you need to take it off. How can a hearing impairment develop? Sometimes they're from birth, Chronic ear infections, absolutely, and, it could be something, an infection that was at birth, or it could be like their ear didn't even develop. It could be many, many different things. So, yes, all of those. Which urine method collection on a infant is most accurate? Remember, infants, they're immunosuppressed. They don't have a lot of their own immune system to fight off bacteria and infections. And if you think that it's going to be a urinary tract infection, you want an accurate urine specimen, and that is a straight calf. Why would you put a bag on an infant? And I'll tell you why not. Because the area, you can't clean it completely. You're going to get skin contamination, and males, you might have the foreskin and then you have the schmegma underneath. And infants, the girls, you sometimes have a little bit of debris, in their labia. You want to just go in, get a quick, accurate, good specimen so that you know how to treat it one time. You're going to bag, you're probably going to have to repeat the antibiotic. It's not going to be accurate. A multi. What is the purpose and function of the family? To drive nurses nuts when we're taking care of a kid, right? Actually, I've enjoyed so many families, and they always gave me the rough families. Difficult family? I'm working, it's mine. They do provide that safe environment, comfort, identity, and it is their values. We don't look at financial assistance. It's all about, growing up in a good, safe environment and learning their cultures. The primary goal in caring for the child with cognitive impairment is to what? If a kid Down, cerebral palsy, autistic, I mean, there's many reasons for cognitive delays. And our goal is to be the best they can be. Optimum development. I've got this little 7-year-old CP, nonverbal, spastic CP boy that I used to work with when I did clinicals. And the kid couldn't talk. But at 7, we used to not treat these kids. We used to not teach them when I first started nursing. Today, this kid is learning colors, he's learning shapes, and he has this little pad that he uses to talk. And the kid is funny and, promote optimum development. And then when you reach those goals, keep going. They'll keep learning more and more than you ever expected. Many infants require oxygen. What type is best tolerated and accurately delivered? Kids are born with TTN, transient tachypnea of the newborn, or they're born, that they just need a little bit of oxygen to keep them going. We can give it in a lot of ways. But in that newborn, that neonate, oxyhood is the best. And the reason is not nasal cannula. Nasal cannula tickles their nose. We usually tape it to their chins, and they're always like this, and they're ripping it off, and it bothers them. They're in a clear dome. They can suck their pacifier, their finger, they can look around, and you can measure that extremely accurately. We have little sensors in there, and we know what they're given, what's being delivered. What is the best practice for school age children with special needs? Special needs, you have cognitive, and then you just have physical special needs. You've got all sorts of kids. You got kids that can't walk due to whatever conditions, but they are smart. So, when possible, they should be integrated into regular classrooms. When we get to week 9, there's about myelomeningocele. I'll tell you about Manuel Louis in a wheelchair because of his condition, smart as a whip. And he was put into regular classrooms. He went to the 8th grade ball, I found out years later. I had him as a newborn. Collecting a heel stick blood specimen on an infant. Now, in infants, we don't always have to do a venipuncture. So we just warm up the heel with a hospital improved warmer. We take a lancet and we do the sides and slowly, easily, we squeeze the heel and we get a specimen. The only time you do venipunctures is when we do blood coagulopathies, a PT, PTT, those things. That's the only time. I mean, a CBC is zero point 0.4 mLs, and a electrolyte, the big chem panel, is zero point 0.8 ml. So it's not much blood. So it's outer aspects. Use that neonatal lancet because if you go too deep, there's the calcaneus bone and you could cause osteomyelitis, okay? And then, of course, that hospital approved warmer. And you don't hold the foot up and firm. It's down with the blood flow down and slowly squeeze it. I've seen heels turn purple from squeezing them too much. Don't do that. Referrals for cognitive impairment should occur when soon as you see them. As soon as we see them, we'll institute that early interventions. And in cognitive impairment would be speech, physical, occupational therapy, and now. And they do really recover quickly. Kids are great. Down's children have frequent upper respiratory infections. Why do you think it is? And it's because their noses are flat and the mucus gets stuck there and then it starts to drip down and that's what causing the cough and keeps all that mucus there. It is that nasal bone, absolutely. A multi. What would be included in the care plan of a patient with moderate cognitive impairment? I mean, number one is always structure, always structure. And then, of course, exposing them to sight, sounds, and sensation, especially if you're talking autistic. They don't like sounds, they don't like certain sensations, they don't like lights and people. Selecting toys that are appropriate and safe so they're not going to swallow it and hurt themselves. And then giving them stuff that's going to teach them stuff. So it's giving them the skills that they need. A multi. Autistic children demonstrate which behaviors? Now, autistic children usually are not diagnosed till about 2 to 3 years old. We might see some symptoms before it, but they're usually don't get that diagnosis till then. They will have, some of these things going on. These kids sit by themselves. They don't like other people. They don't like lights. They don't like loud noises. They don't want you to touch them. They're not going to look at you in the eyes and they're not going to be able to speak. Their languages are really delayed. And you call them and they don't even want to be bothered with you. So they wouldn't even respond to your name. A multi. Children with autism have better outcomes if what? I worked with this little Downs boy who was autistic too. I mean, it's what you call the double whammy of cognitive delays, right? That kid would come in the morning, take off his backpack, would put it in his cubby, sit down, wait for vital signs. When they were done, he'd go play with his toy because a structured routine. He did the same thing every day since a young child. And then you got to teach him some sort of verbal communication skills. Teach them how to express what they want. That's going to decrease those bad behaviors because they can talk to you. And you're just because they're autistic, downs, whatever they are, They should not have bad behavior. So you will discipline them for unacceptable behaviors. Therapies with licensed therapists only? What about mom and dad, brother and sister? They're also going to be doing these things with them. So it's not only with license. As many people who can will help these children really progress. Another multi. Fragile X causes. Second most common cognitive delay after Downs. Very similar to Downs with a little bit of differences. So you'll have the intellectual delay, learning difficulties, just like Downs. Physical deformities are different. There's big ears and big jaw on these. And these children are aggressive, requiring and like very active. They're going to like Zoloft for, to calm them down. And they're going to be on Adderall for that extra, activity. So the difference is medications and they're not the almond face and the tongue and that. It's the big ears and the big jaw that you see on these children. These children are harder to treat because we've got to get them on the medications to keep them calm because they are aggressive. Causes of autism. Autism hits boys more than girls. I worked with a nurse who had one boy and a year later had another, and they both had autism. And she's been working very, very hard and very, very active in the autism community now. We don't know why exactly. Genetics, abnormalities, unknown. But as I said, more males than females. Ways children with hearing impairments communicate with each other. I think it's great. Kids, they don't even have to know each other's language, do they? And kids will sit there and play and get along with each other. Well, hearing impairment is really basically the same. It's sign language, finger and lip reading. It's all the above. They just know how to talk to each other even without talking. What is amblyopia? This is one of your sensory impairments, and that is vision. Amblyopia is what we call the lazy eye. One eye is to the right, left, up, or down. It's just lazy. How do you treat it? Well, the muscles in the eye aren't strong enough. So cover the good eye with a patch and make that bad eye work, and it will strengthen the muscles, and they do really well. How would you help encourage a preschooler to be less apprehensive when taking their vital signs? And preschoolers want to touch and play and know, and making it a game, telling you my number is this, what's your number going to be, and let them touch it and push that blood pressure machine, and the kids do really well. They'll let you do mostly anything when you do that. What child may be more stressed when hospitalized besides the cognitive delayed child? And that's the child who's been in there a lot. The kid who's never been there doesn't understand a hospital. The kid who's been in there more than once, they've already had maybe a bad experience. So it's the one with frequent hospitalizations. A toddler has a hard time fixating on a single point, and the child's eyes cross the midpoint. I mean, we know there's binocularity at birth, and by 9 or 12 months, they're going to work together. Well, these eyes are still not working together. So, what would that be called? And it's called strabismus. Strabismus. That's when they don't work together. Nystagmus, they're sort of twitching, but strabismus, they cross. They can't get there. And of course, this child will have a hard time with depth perception. Another multi. Safety and administering medications to children include what? It's always milligrams per kilogram or micrograms per kilogram. Name bands, you're not going to give a med without a name band on there. And if you need to give a med and name band's not there, you tell the charge nurse or admissions, get one up here now, because you don't do it before that. Asking the child their name, many of them won't give you the proper thing. And then checking a room number, that's the old way of doing it, and that's where all those mistakes happened. We only administer medications based on their name band. Okay? What can help the parents to make a baby swallow their medicine? Some kids get it in their mouth and go in your face, right? How are you going to stop that? I've taught this trick to many a parents. And if you take and put the medicine in their mouth and you blow real quick, they swallow it. Now, I used to do it before infection control and all of these things going on, but now I tell the parents to do it and they swallow it right away. Again, never in the back of the mouth. It's going to come back and it's going to vomit you. I might pinch the cheeks a little bit until I could blow in them. Putting it in food or formula, that's questionable. Because remember, if they don't take all the food or all the formula, did they take their medicine? And it would be never in a bottle, never in formula, maybe in a little teaspoon of, you know, um, applesauce or something, but never just in the whole food. Okay. It's that strong blow in their face, and and they swallow it. Treatment for amblyopia is, remember, it's a lazy eye. Again, cover the good eye, make the bad eye's muscle make it work. Very good. You were listening. The nurse is discussing sexuality with the parents of an adolescent with cognitive impairment. What is important? You have let's say a child, a girl who's Downs, even a boy. Why would you even want to talk sexuality? One of the most abused areas of children there are, because they don't know better, do they? An well-defined concrete code of sexual conduct. Good touch, bad touch, and who do they tell to, make themselves get out of that situation? They really need to be taught this because of there's really sick people out there, right? Another multi. A child is asking mom about his sibling in the hospital. How can you alleviate his stress and fear? This is a reality. You have a kid in the hospital and they've got brothers and sisters at home that are worried about them. Plus, mom or dad is not home the way they should be, so they feel neglected. So, what do you do? Bring them to grandma's house, right? Have a kid make them a card in the hospital if they can, or at home. Send it in. Never tell him he's okay. That doesn't mean anything to a kid. And if they're going to go in and have a visit, be prepared for what they're going to see. If they're in the ICU, are they intubated? Do they have an IV? Do they have a monitor? What does the bed look like? Have them prepared, okay? I used to, as a nurse, think about the brother or the sister at home, and I'd give mom or dad to bring home a coloring book and crayons that the hospital has there, hospital-based stuff. Or I'd make bows for my girls, and I'd send bows home for the girls at home. And that kept them really involved. We're lucky today we have FaceTime. That wasn't always around. A multi. What are some best practices when a child is in pain? Always remember to medicate before we do anything on a child who is in pain, whether it's incentive spirometry, getting them out of bed, whatever. We would do that with adults, do it with kids. Always give what they're telling you to give. Don't second guess it. These are doses, especially morphine. It's not scary. It's a really been out forever. It's a really accurate dosing. Repositioning, cold packs, hot packs, distracting them, coloring, music, TV, something. Do something to get their mind off of it after you medicate them. And all those together will help this child. A multi. Children can be critically ill for long periods. How do you prevent pressure ulcers? And yes, kids do get pressure ulcers. It's just not the old people. I mean, some kids are in the hospital 6 months in the ICU. So you always want to keep them dry. All right. You want to make sure that you're changing the diaper or whatever you have under them frequently, turning them. Absolutely. Draw sheets. You don't want to take them and shove them up and down the bed. They're sheer, just like adults will after a while. And then I use all different things to prop them. I use baby blankets and pillows, stuffed animals. I used to use the little tiny little ones with the little tags on them and put it underneath their endotracheal tubes. So the baby or young child would be looking at their little stuffy toy, right? Very non threatening. So, absolutely. Adults are not the only people who do get ulcers and breakdown, kids too. Last question. Of course, it's a multi. Young children can be stressed by being in a hospital. How can you decrease this stress? Again, it's routine, parents, and then the toys, food, whatever, you can come home. I mean, number one is keep them parents there, and then have that routine, and these kids will do a lot better. Number three, well, good job. Number two, Nate. Look at you, Nate. Number one, Sierra. Good job, guys. Number four, Sanchez and an Anna. So that is our class for tonight. Again, you'll see your exam grades by Saturday at 2 o'clock. I'm going to go over every question, making sure that they were fair. I know there were some tricky ones there. If I don't feel they were fair, I will give them back. Um, and this is with all the professors together. We're getting together at 1 o'clock on Saturday. So soon thereafter, you will get your scores there. When you see your grades, anybody 78 or less, please make an appointment with me. I want to go over these exams with you, okay? Very important to do that. So, thank you so much for tonight. Lene, thanks for your patience. I appreciate it. And you all have a really good evening. Take care. I'll be
Thank you.
posting the PowerPoint too, so you got both.
Thank you.
Welcome.